Hello everybody and welcome to the HacettepePathology Case of the Month session. And in this month I'm going to share you a biopsy from an elderly woman and she had a gingival lesion, and the diagnosis was synovial sarcoma in the outside clinic, and it has been consulted to us. Now we have this squamous epithelium and we have tumor ulcerating the epithelium, and once we look at a higher magnification we see a spindle cell proliferation intersecting bundles, and another area is more like fascicular growth, long fascicles intersecting each other. It superficially resembles synovial sarcoma, but synovial sarcomas are usually located in a deeper soft tissue, although it can be seen in any part of the human body, including head and neck region. Mucosal synovial sarcoma is highly it should be highly exclusive, and sometimes mucosal erosions can be seen in the large tumors, but the synovial sarcoma are usually deep-seated lesions. And here we have the tumor cells and epiderm, let's say the squamous epithelium, mucosal squamous epithelium has a very transient connection, as you see here. And in an elderly patient with a mucosal lesion like this in the head and neck region, two tumors should be in mind. And the one of them is a squamous cell carcinoma spindle cell variant, or let's say spindle cell squamous cell carcinoma or sarcomatous carcinoma, and the other one is melanoma. And of course, when we look at the mucosa more carefully, we see some other areas, like here, just some small nests here and there, and they are just they just remind me a melanostic lesion. And of course the immune panel should include keratins and maybe P63, and of course S100 SUX10. And the other feature of the tumor is there's no pleomorphism at all here. They are not pleomorphic, but highly mitotically active, as you see here. And this is again a characteristic for spindle cell melanoma, or again some spindle cell squamous cell carcinoma. And this is S100, and S100 was negative. And this is these are the stained cells are Langerhans cells, dendritic cells, which accompanying the spindle cells, and also they are located in the mucosa, mucosal surface, and this is negative. And as far as we are, the suspicion of the melanoma is high, so we have to order SUX10, because let's say the P63 was also negative. And smoking history is also important to diagnose spindle cell squamous cell carcinoma, but here again keratin, and these markers can be also negative in spindle cell carcinoma, but keratin 18 is and P53 can be helpful here, but here in this case again squamous cell carcinoma is the secondary, because we also performed SUX10, which is diffusely and strongly positive. And as we also noticed the presence of junctional component, we are now good with the diagnosis of spindle cell melanoma, and they are usually HMB45 and melanin negative, as you see here. But in this case, some HMB45 positivity, dot-like positivity, is also encountered, as you see here. This is actually I wasn't expected that. My diagnosis was already done with the spindle cell melanoma, but HMB45 was like a blessing just on top of the diffuse and strong SUX10 positivity. So some melanomas, just remind us, some melanomas can be S100 negative, especially in the mucosal areas in the rectum and here in the head and neck region. And if you suspect melanoma highly, you have to order S100 and SUX10 together. Thank you very much, and see you next month.